So I do have a few questions I'd like to pose to our distinguished panel. Beginning first, as Dr. Frieden, as you said, supportive services are important with no effective vaccine or drug treatment. You outlined how important those services are, including hydration and I'm sure antibiotics to deal with some of the other co-infections. Now, I wonder if you could just tell us, is there any disproportionality in result when it comes to whether or not we're talking about a frail elderly person, a woman, a man, a child, a woman who happens to be pregnant, or any of the other, someone who has a compromised immune system? What has been, the MO of that, if you could? Secondly, I know that treatment centers, for example, in Guinea, there are some 3 to 4 treatment centers. But again, it's very hard for people in that country, as well as the others, Liberia and Sierra Leone as well, to get to those treatment centers. It's a long trek. Very often, the ride could, not only the person is very sick, others could come in contact with him or her. There seems to be an overwhelming need. One of the points that I think needs to be underscored that is underappreciated in many places is that in dealing with someone who is dying, especially in that part of the world, there is a psychological trauma with being alone. So it almost exacerbates the spread of the disease because people want to be around, near, touching, and when that person is highly infectious, that's when family members and others might get it. If you could speak to that. The lack of testing areas, whether they be as part of the treatment centers where there's a testing lab. It's my understanding, especially since this masks and parallels what other, it looks like other things, but it's Ebola. But unless you get that test back, how long does it take to do the test? And again, is there any way of standing up labs? I know for a fact that, especially through the work of Bush's PEPFAR program, which has been followed up with Obama, doing the same thing, and the idea of building health capacity and labs in Africa is a very high priority, and now we're seeing where inadequate labs or lack of labs leads to people being sick and not even knowing it. Let me ask you, the courage of the healthcare workers, I think needs exclamation points. I mean, and I know you are as well, and you go on the front line yourself and go into, all three of you, into contagious areas. But Dr. Brantley and Ms. Whiteball and others who put their lives on the line, motivated so often by faith in the case of Dr. Brantley. And I mean, I've read some of the things his wife has put out, the prayers that are being offered up, not just for him, but for all of the victims. In Liberia, there have been 60 healthcare workers infected, 35 are dead. In Guinea, 33 healthcare workers affected, 20 dead. How does a country now attract or retain healthcare workers who say, if I go into that arena, the prospects of me getting this are very real? Is there enough protective equipment? The gowns, the plastic, to mitigate the possibility of transfer. And finally, and I do have other questions, but I'll yield to my colleagues, there are a number of, as I said at my opening, promising drugs. ZMapp is one of them. Certainly Tecmera, which was in phase 1 trials, and yet the FDA has a hold on it. They were contracted by the Department of Defense. From what I've read, and it's only from what I've read, that the available data, it was showing promise, and I'm wondering if there's any way to accelerate, knowing that you don't want to obviously put something out there that is risky, because Ebola is not 100% fatal, as we all know. We don't want people getting sick from the remedy or supposed remedy. What about accelerating that? Is there an effort to do that? And my final question is about the safety of airline flight. Many people have contacted my office to ascertain, how safe is it to fly, perhaps next to somebody who's maybe changed flights en route to the United States, coming from Liberia, for example. And are the efforts at the airports, particularly where there's a large diaspora population, I don't know if you have enhanced efforts there, where there's people from West Africa are more likely to go, but are they up to the task of detecting at point of embarkation of passengers who might be sick from Ebola?
So let me try to quickly give you clear answers to all of those questions. The first is the relative case fatality rate of different groups. And in the current outbreak, the data is still too foggy for us to give you clear data. There is not the kind of robust data that we will have eventually but don't have now to give you what we would call the case fatality rate for different groups. But there is one very intriguing historical fact, which I think is worth mentioning. In 1967, there was a laboratory accident in Marburg, Germany. The Marburg virus was then identified. Marburg has a similar fatality rate to Ebola, if anything a little higher. It's around 80%. The outbreaks have been in the 80% range in Africa. The case fatality rate in Germany in the Marburg outbreak was 23%. Now, that might have been because of the better supportive care. There was no specific antiviral treatment. Or it might have been because people were healthier going in. We don't know. But we do know that it was dramatically different. And I think that's an important point. Good supportive health care is a proven way of saving lives. And we should never lose sight of that. Second, in terms of treatment centers, you're absolutely correct that there's a challenge in getting to treatment centers. And that's that is in fact the #1 priority for the DART team, which USAID is convening and CDC is leading the public health aspects of, which is on the ground today in Liberia to assess. And the biggest challenge is both in the city of Monrovia, where there continue to be chains of transmission, and in that tri-country area. So looking at whether one facility or multiple facilities and where the facilities would be, that's a critical issue for us to determine in the coming days. Treatment centers, as you point out, are very important to support. I was speaking with the American chargé from Sierra Leone, who was speaking very movingly about the patients and their isolation in the treatment centers, and simple things like giving them cell phones so they could talk to their family, or things that they could do while there was very important. And if patients don't believe that they're going to be well treated in the treatment centers, they won't come in, and they may continue to spread it in the community. So good quality care is very important. In terms of testing, you're absolutely correct. As you know, Mr. Chairman, with support from PEPFAR, the CDC has helped create the African Society for Laboratory Medicine, and that has, for the first time ever, had high-quality laboratories established all over Africa. These countries have not been PEPFAR-focused countries, so they have limited activities in that area, but scaling up laboratory testing is important. We'll do that in 2 ways. First, by finding laboratories. This isn't simple laboratory test. This is a real-time PCR. The results come back within a day, but false contamination, false positives are possible if you're not scrupulously careful, and that would be a real problem. So we will scale up the labs that can do testing, and we're working with international partners on this who are involved and with the Defense Department, which has a very active program, for example, in Sierra Leone, and is providing services there, and with the National Institute of Health and Institutes of Health, which has been very helpful. We'll also establish safe specimen transport means. We've done this in Uganda, where we can very safely transport. Hard to get a lab out all over, but quite possible to get transport into the lab, and that's what we'll establish in the coming days. In terms of the courage of healthcare workers, I certainly agree with you, and it's an issue not just for healthcare workers, it's an issue for patients. We've heard that with healthcare systems less functional, problems like malaria may become more deadly. So the impacts of Ebola aren't just Ebola. There are the other conditions that aren't treated because of Ebola. So responding is so very important, and protecting the responders is so very important. So a key aspect that we're working on with the World Health Organization, with the countries, with USAID and others, is making sure that there's effective personal protective equipment there for healthcare workers. We believe it is possible to take care of Ebola patients even in Africa safely, but it takes meticulous attention to detail. In terms of the promising drugs, I can assure you that the U.S. government is looking at this very carefully and will look at any way to try to expedite development or production, but I don't want any false hopes out there. Right now, we don't know if they work, and we can't, as far as we know, have them in any significant numbers. We hope that that might change, but these medicines that have been used in the experimental cases, as far as I understand it, are not easy to use. They require infusion. They may have adverse events, and basic supportive care needs to be in place as a prerequisite to giving many of these treatments. So whatever else we do, we have to do the basics right. And we might or might not have effective and available treatment in 3 months or 6 months or 1 year or 5 years, but we today have the means to stop the outbreaks. And finally, in terms of airline flights, we do have teams in the affected countries who are working with their, basically the equivalent of their border patrol or border protection services, helping them to do screening at the airports. It's not a simple measure. It's key first to reduce the number of cases. That's what's going to be the safest. And there are other things that can be done at airports in terms of questions to be asked or temperatures to be taken or lists to be cross-matched against known patients and known contacts. But all of those procedures do take time to set up, but we do have teams working on them now.
Dr. Friedman, if I could ask you, if somebody is in proximity to a sneeze or a cough, is that a mode of transmission?
In medicine, we often say never. So in general, the way we have seen the disease spread is by close contact with very ill people. As you know, the individual who traveled from Liberia to Lagos did become ill on the plane, and we have assisted those countries to track the travelers who traveled with them, and as of now have not identified illness in any of them. But in general, it is not from a sneeze or a cough. In general, it's from close contact with someone who's very ill. But we do have concerns that there could be transmission from someone who's very ill. That's why.
So at the fever stage, if somebody is on board, is that would be construed to be very ill? You're not likely to get it from somebody who is at fever stage?
If you're not going to get it from someone who's not sick with Ebola. So if they're just clearing their throat or sneezing or coughing, but they don't have a fever, they've not become ill with Ebola, they're not infectious to others. But if someone became ill on the plane and was having fever or started bleeding, then, for example, that might present a risk to those who came in contact with that and didn't take appropriate precautions.
Is there a way of advising airline personnel, particularly flight attendants, who, again, might be in very close proximity to the whole plane, and there could be someone on there? Does CDC advise them and the airlines, like Delta, which flies numerous flights to the region?
Yes, we have provided detailed advice to the airlines.
Let me just ask you, Ambassador Williams, very quickly. You spoke, and I think it was a very good insight about the handling of for funeral arrangements and just generally that sensitivity to the culture. I know it's part of the public information campaign in Guinea, for example. Some 9 million cell phones are being used, and text messages are being sent with a number for the Red Cross, and it's. One of the text messages are, the bodies of Ebola victims are very contagious. Do not manipulate, call the Red Cross. Now, I'm wondering if there's any thought being given. I remember after Operation Provide Comfort, when the Kurds made their way to the border of fleeing Iraq after Saddam Hussein. I was there about 5 or 6 days after that, and our military was on the ground, and they were using PSYOPs to educate and leafleting that was done in a way that we would use in a not-so-benign situation. In this case, it was to get food out and meals ready to eat. And it was amazing how that kind of information made the Kurds, who were at great risk of the elements and starvation, very aware of what they needed to do. Is there any thought of helping the Liberians and the other countries with again, a benign PSYOPs effort to make people aware? I know that radio is being used. But it seems to me that more needs to be done. Any thoughts?
Thank you, Chairman. I can't say that we've moved to the point of PSYOPs, but I think you are hitting a very, very important issue, which is that culture makes a difference, and you have to adjust your messaging and do the campaign according to the sensitivities and the routines and the practices per culture. What was extremely effective in Guinea was not only what you mentioned, Mr. Chairman, but the fact that they started talking about survivors, and the survivors came on the radio. They went around and said, "Look, I was sick, but this and this and this happened to me. I did such and such, and I'm still alive. You should go get treatment. You should isolate. You should make sure people know you have this." So that's very, very important. Our military right now is helping in the ways that have already been described, as far as with logistics and making sure that we can get in body bags, protective equipment for the healthcare providers, and that's where we are so far. But we are relying upon the host governments to help explain to us what are their most effective, what are the sensitivities, and what messaging needs to get out. And then we were helping with the means of the communication, but not the actual message, because they know best what the people need.
Thank you. I yield to Ms. Bass.